Ladies and gentlemen, thank you again for your attention. I'm Mia Keeys. I'm Congresswoman Robin Kelly's Health Policy Advisor and the Policy Director of the CBC Health Braintrust. We're really excited to welcome these fantastic national leaders in health and in Congress. More than likely, especially if you're from this area, you recognize Chairman Bobby Scott to my immediate right. Let's give it up for Congressman Scott. Congressman Scott represents the 3rd District of Virginia. He's actually the first African American to represent that district, or represent Virginia in Congress since Reconstruction, is it? Yeah, that's pretty incredible. And we've come quite a long ways, and so we're hoping to unpack a little bit of that later. He's also the chair of the Education and Labor House Committee, and so we are hoping to have a conversation a little bit about intersections of education and opportunity with respect to wealth, or to health and wealth, right? Okay? All right, I'm gonna actually leave her for last. But this woman here to my left is no stranger. We have Dr. Donna Christensen, and so she is also a former member of Congress and representing the U.S. Virgin Islands. Let's please welcome her properly. And if you were here earlier this morning, you were able to catch her fantastic presentation where she broke down a lot of the social determinants of health and how we need to be thinking about health both in a clinical sense and in a non-clinical sense. And hopefully we can infuse a lot of that into the policy conversation that we're going to have right now. And right here to my right is my boss and someone I really greatly admire. You can't tell that I'm blushing up here, but I am blushing. Because I truly admire this woman. This is Congresswoman Robin Kelly. She represents the 2nd District of Illinois. Congresswoman Kelly serves on the House Committee of Energy and Commerce and on the one of the major subcommittees where we do a lot of health-related work. And she's also the chair of the CBC Health Braintrust. And I should also say, Congresswoman Christensen is her immediate predecessor. And so you are in for an entire treat in terms of what we're going to talk about today. We'll later be joined by Congresswoman Sheila Jackson-Lee. She represents the 18th District of Texas. And so once she comes up, we'll do a proper reintroduction of Congresswoman Lee. Okay? Are we all set? Great. I'm going to shut up and leave the floor to Congressman Scott. I'm hoping that he can tell us, just give us an overview. And by the way, we're talking about the future of healthcare, where our nation is going, but we also have to talk about the issues and challenges and the wins that we're facing now. So perhaps you can tell us a bit.
Well, thank you, Mia, and I appreciate everyone being here, and I especially appreciate Robin Kelly's leadership on the Health Braintrust, following Donna's distinguished leadership as a medical doctor and very active in the National Medical Association. But when we talk about the Affordable Care Act and what we've been able to accomplish, I think it's extremely important that you start off with where we were before the Affordable Care Act. What was going on when we passed it? Millions of people every year were losing their insurance. Costs were going up through the roof. People with pre-existing conditions, if they could get insurance, were paying an arm and a leg for it. The policies you get didn't have quality benefits, and that's where we were. And then we passed the Affordable Care Act. People with pre-existing conditions can get insurance at the standard rate. The cost, although they kept going up, were going up at the slowest rate in the last 50 years. More and more people were getting insurance. It had essential benefits, so it covered what you got. So there was a significant difference. Now, if you want to know how good it is, you just look at the fact that for a decade, the Republicans were whining and complaining about how bad it was. And when they came in with the president and both the House and the Senate, they had the opportunity to produce their version. And then CBO scored it. About 20 million fewer people would have insurance if that thing had passed. Costs would go up 20% the first year. The policy you got wouldn't cover what the policies cover now, and those with pre-existing conditions would start losing a lot of the protections they have now. Yay! Really? They passed it. And but for Senator McCain's famous thumbs down, the Senate would have passed it on a tie vote with the Vice President passing it. They've tried to, since they couldn't repeal it outright, they've tried to sabotage it. Now, one thing apparently they don't recognize, you know, they don't believe in science, they don't believe in arithmetic, because they had a bill they were bragging about a bill on the floor. They're going to cover people with pre-existing conditions. Guaranteed issue. They're a little kind of fuzzy on whether or not what kind of price you'd pay. But we have had experience providing coverage for people with pre-existing conditions without either significant subsidies for everybody else or a mandate. And every time they've tried it, the thing has spiraled out of control. Because if you can wait until you get sick before you buy insurance, people will wait until they get sick before they buy insurance. The insurance pool, on average, is sicker. And so healthy people start figuring out they can't afford it. On average, the cost goes up. More healthy people drop out, the costs go up. The sick people are going to stay in the pool. But as healthy people drop out, they have a name for the process. It's called the death spiral. It spirals out of control. They tried it in Washington State. It took them 3 years where nobody could buy insurance. They were in the death spiral in New York. And when the Affordable Care Act came in, the cost for individual insurance went down more than 50%. And so we know that the Affordable Care Act isn't perfect. But it's a lot better than the Republicans were going to come up with, and it's a lot better than what it was. There are things we're trying to do now to improve it. There are a few glitches along the way. But the last thing we need to do is to sabotage the Affordable Care Act. They're doing stuff like withdrawing advertising and withdrawing outreach. Now, advertising and outreach, who is that going to reach? It's going to reach healthy people. The sick people know they need insurance, so they buy it the first day. All that, so if you cut out the outreach, a few healthy people don't come in, and so what does that do? Raises, if you appreciate arithmetic, the average price just went up. Everything they've done, they've got this thing called association plans, where a group can come out, and if they're healthy enough, they can pay less. But if they're paying less, simple arithmetic will tell you everybody else is what? Paying more. And well, y'all are a little ahead of the game. And so everything they have done to sabotage the Affordable Care Act has just made life miserable for everybody else. The essential benefits are extremely important. One benefit, mental health, has been a kind of an unsung success, because if you've got insurance, you've got mental health coverage, that's substance abuse. So all the opioid problems, people can get treatment and pay for it. And so the Affordable Care Act has been a success, not as much of a success as we'd like, but it's done a whole lot better than where we were, and a whole lot better than where the Republicans would have taken us if their bill had passed. And so as we just go through the discussion, we'll talk about a lot of things we can do to improve it, and other options that we may have. So thank you, Mia.
No, thank you very much, Congressman. Can you all hear me? Okay, great. I think the point that you made about going back to where we were before the ACA is really quite critical to understand where we still need to go, and the issues as you describe them. And I want to pull you into the conversation, Congresswoman, to tell us about just how far we've come. Earlier today, you spoke about the Health Equity Accountability Act, HEA, which you mentioned has been introduced in the House since 2003. Ms. Kelly and the other Tri-Caucus members have reintroduced it every Congress since then, and it's not yet been passed. So if you can tell us about where we've come and remind us of the tenets of HEA and how they were implemented into ACA.
Sure. Well, as I said this morning, having had the Health Equity and Accountability Act around for 8 or so years, once we had the opportunity with the ACA, we grabbed it and we put many of the provisions there. I'm sure I'm going to forget some. One was we created the Institute at NIH. It had been an office. We took it to a center, but in the ACA we were able to create an institute which gives it much more trans authority much more funding. It could still take some more funding, but the National Institute for Minority and Health Disparity Research. We also created offices of minority health in agencies in HHS that did not have them. What else did we do? We created the community health workers grants. We created PCORI, the Patient-Centered Outcome Research Institute, which has been doing great community participatory research. They bring in caregivers, patients, as well as providers and advocates into the decision-making even about what research needs to be done. And then communities do the research themselves. And they have always, from the very outset, hi Sheila, from the very outset included the social and economic determinants of health within the research that they're doing. We insisted that whatever research was being done in any of the provisions that minorities, women, and people with comorbidities or disabilities needed to be included in that research. We increased funding for the territories. How could I forget that?
I was hoping you would say that.
We did really great in the House. We started out, we wanted state-like treatment for Medicaid, which we do not have. Our Medicaid is capped, but the House provided a significant amount. I think it was like $13 billion or something like that for Medicaid for all of the territories. That's Puerto Rico, Virgin Islands, American Samoa, Northern Mariana Islands, and Guam. As well as included all of those provisions and some more that I'll think about as we continue the discussion. But we almost lost it when it left the House and went to the Senate. So the Tri-Caucus, Asian, Hispanic, Black, also supported by the Progressive Caucus, spent many evenings over at the White House speaking directly with President Obama and over in the Senate to make sure that we got back as much of those provisions as we could. And we got back some, maybe not as much as we got in the House, but we were successful in that.
And that was quite a fight.
It was quite a fight. Even a fight on the Institute and the Offices of Minority Health.
We're going to unpack that a little more later. I just want to take the moment to introduce to some and certainly to just remind others of Congresswoman Sheila Jackson Lee from the 18th District of Texas. Welcome, Congresswoman.
Thank you.
Congresswoman Lee has been in office for 20 some odd years
A good
now.
number of years.
Yes, ma'am. Right, and so you bring with you such a institutional wealth, and so we really appreciate you coming today. Congresswoman Lee serves on 3 House committees, on the Judiciary Committee, Homeland Security, and also recently on Budget. Yes, so you bring, I'm sorry?
Thank you.
Yes, indeed. So certainly read more about all of our members of Congress if you don't yet know much about them. We really want you to make certain that you know who your champions are in the health space. I actually want to stay with you, Congresswoman, and I hate to pick on you very quickly, but I'm going to do it.
Have you picked on the other ones yet?
We picked on 1 and 2. We're going to come back to this one here. I always save my favorite for the last. I'm going to pick on her a little bit. But just as you were walking up, Congressman Scott talked to us about how the ACA itself was never perfectly designed, right? And no milestone legislation ever is. There's always, if you look at Medicare and Medicaid, if you look at the ADA, the Americans with Disabilities Act, all of these acts have been improved upon over years, right? But there are some really very disturbing things happening with the ACA. Most recently, a major lawsuit in the state of Texas over the constitutionality of the ACA and its pertinent tenets. And so I wonder if you can just talk to us about, build on Congressman Scott's remarks, talk to us about the ACA, its significance, where we still need to go, and also incorporate the lawsuit.
Dr. Matthews, thank you so very much for having me, and as well, I'm delighted to be here with the distinguished panel that you have, Congressman Scott, Dr. Kelly, and Dr. Christensen. Hello, everyone. How are you? I have just landed from from Houston, Texas. I guess I'm in Washington, D.C. That's what happens when you're on an airplane. And I have a button on here where I started out this morning, Houston Peace, and I'll wrap some of that in the mix of my conversation. It is the community standing up in Houston against the atrocities of gun violence among our kids. The Affordable Care Act, the one thing I can say to medical professionals, because you believe in deliberative facts, I've come to use the terminology from Bobby Scott when we were on judiciary best practices, but you have a sense of methodical research dealing with facts and then following the facts to either deal with new research in pharmaceutical drugs or practices and procedures, medical practice and procedures, all comes about through a long period of study. Well, I think one of the singular bills that had a long track record of study, listening to many of you in this room and other providers and communities and academicians and medical doctors, and Dr. Christensen was in the Congress then, was the Affordable Care Act. It traveled through the Congress for at least a 2 to 3 year period. Every single committee, almost every single committee, and the Judiciary Committee held hearings on their aspect of the Affordable Care Act. So in terms of critiquing or in terms of adding your various provisions, meaning our friends on the other side of the aisle who wanted to participate, every single committee had an opportunity to have a piece of the Affordable Care Act. The Affordable Care Act, I believe, is crucial, and certainly Texas was used as one of the major poster child for the uninsured. Big oil-rich Texas had 25% of its population uninsured. At least 5 to 6 million Texans were uninsured. Now, we have made a dent in that, and it seems tragic that a group of 20 Republican state attorney generals, heck bent on the destruction of this legislation. And it baffles me when people say that well, the whole population wants to do something with the Affordable Care Act, meaning to get rid of it. And we all know that it doesn't work. And I'm glad you said the other initiatives, health initiatives, it is not, Medicare was not perfect. So in any event, and the administration at the time Obama stood on the side of defending Obamacare or the Affordable Care Act. And then last week, this administration spontaneously, and as I understand, over the opposition of well-thought people in the administration, the President of the United States stood up to say, I want to explode or implode a system with having no other system. And just to emphasize, we worked very hard, and I heard Dr. Christensen, I started when I first came, and I came a little bit before her, to deal with the Office of Health Disparities in HHS, and actually had an amendment along with former Congressman Jesse Jackson that actually got in helping to establish the beginnings of that department. One of the reasons I come from a community with Hispanics and African Americans, Anglos and others, but in particular, there were stories cited with Hispanics, for example, the language barrier, but also the way doctors have to relate to more senior Hispanic women or more elderly black men. And so there was a question of how medicine can deal with these populations and their attitudes about the privacy and other questions. So we really worked hard to have that. We worked hard to deal with the Centers for Disease Control having the ability to assess horrific situations in our community that no one else wanted to study, such as the crisis of gun violence being a health issue. We worked hard to provide for medical students and other medical practitioners to have funding to go to school. And just as an aside, and I will wrap up on its importance, many of you may have heard of New York University now having, from this day forward, tuition-free medical school. Their medical school is, if you get in, it's completely tuition-free. But in the discussion they make note of the fact that the numbers of African American males as becoming doctors is near nil and zero. That's a crisis. It is a crisis for any population to not be well represented in this whole question of the medical arena, when that is, I believe, almost at a certain point, a fodder for us putting another constitutional amendment saying the right to health care. The right to health care, or interpreting the Fifth Amendment of due process of the right to health care. Because without health care, what we see is the legions of people who are deceased or on the way to a debilitating life that will ultimately wind up in their death. And I want to finish on this note. I am a breast cancer survivor. During the time that I was dealing with breast cancer, and one of my dear friends, or maybe a little bit before, succumbed to triple-negative breast cancer. In the normal course of debate, that was not something that the general population was aware of. It just wasn't, you had breast cancer and you just had breast cancer. Triple-negative breast cancer, that many of, obviously you know, is more deadly, less time, needs an immediate diagnosis, if you will, or to be treated. And since it pertains a lot to women of color, both Latinos and African Americans, and I met so many people when I started working on this issue. Latino young women came up and said, we just lost our mother with triple-negative breast cancer. So the point is that the importance of the Affordable Care Act was to open the medical system to individuals who would not have access and to create for them a pathway to live. And it is shameful that we're now at a point that it is not recognized for what it was, and also to open the door for the diversity of medical professionals dealing with the expansive medical population that was very diverse in this increasingly diverse country. So it is crucial for my state, but it's crucial for the nation. And I am grateful for the Tri-Caucus and the Congressional Black Caucus in particular, that we are really laying it on the line to fight against the destruction of the Affordable Care Act, or a system of care.
That's right. That's right. You wanted to add something?
Yeah, I just wanted to add two other things that some of which was referred to, but one, we also increased the investment in HBCUs and other minorities serving institutions in the Affordable Care Act to train more health professionals of color. But we created a public health council, which was to and did include every agency of government meeting and chaired by the Surgeon General to look at all of the programs that transportation, housing, agriculture, small business might be creating to look at the health impact, or to ensure that whatever they were doing would have a positive health impact included, and definitely not an adverse health impact. And that was a very important way to bring, to address also the social and economic determinants of health, and make sure that we were addressing health in a more comprehensive way nationwide.
And speaking of nationwide and addressing social determinants of health, I want to pull out two threads that that the two of you mentioned, and ask Ms. Kelly to comment on this. So you mentioned that the ACA was one of the most debated bills in all of the history. I know this is a complete understatement.
We did not only read it. Mm-hmm. Let me clear that up. We not only read it, but we went through a week where the committee staff and the committee chairs went through it title by title with us in our Democratic caucus. Mm-hmm. Yes. Mm-hmm. One other thing that I'd like to clear up, because you hear it said all the time, that President Obama promised that we would be able to keep our doctors, and that wasn't true. What happened was the insurance companies narrowed their networks. Mm-hmm. And that's, if someone was not able to keep their physician, that was the reason why. Mm-hmm. That was something that was done by the insurance companies, not intended for the bill. You were supposed to keep your networks
And
wide.
NMQF works with insurers, and these are certainly, this is great feedback that we want to make certain that on our cross-sectoral conversations that we keep bringing that up so that we don't, it doesn't happen again in the future. But, okay, so the ACA was debated over and over and over again. I think it was something like 80-something times, right? But it was finally brought to...
And committee hearings in the thousands.
In the thousands, right, exactly. It was
And just
incredible.
one point, Senator Grassley also, if you remember Dr. Christensen,
If you can, Congresswoman, I want to hear more about that, but really quickly, I just want to bring
actually
Ms. Kelly...
changed the language, I just wanted you to say.
He
of the
certainly
bill.
did,
He
yeah.
did.
Let's put a pin in that because I don't want you to lose your thought with that.
No problem.
But at least it was finally brought to the floor. There have been bills that Congresswoman Kelly, for instance, about disease-specific areas or even major social determinant of health with respect to violence that had never been brought to the floor. Gun violence, for instance, right? So just recently, and you have what, 7, 8 bills that you've written with respect to gun violence?
Something to that effect.
Exactly. Yeah, this has been one of your major champion issues since you came into Congress in special election in 2013, and still today, right? It's only recently that we've seen a bill with respect to gun violence come into committee. So can you talk to us about that and give the audience more of an appreciation, in addition to the ACA, about the political process, the policy building process, and talk to us about gun violence, please.
Well, one thing I just wanted to comment, I wasn't here during all of the ACA discussion, but that's just exactly what you said, that there wasn't a lot of discussion. People didn't read the bill. I didn't know if you really read the bill or not, honestly. And then the other thing was that it was never discussed, that it was just jammed down people's throats. And then to hear my colleagues who were here said that it was 2 or 3 years, and I know President Obama went all over the country speaking to people about the bill, but that was the conversation that was out there. As far as gun violence, which is definitely a public health crisis, when we passed the background check bill and the enhancement background check bill, better known as the Charleston loophole, that was the first time in over 20 years that we had passed a gun violence prevention bill. And I've been here 6 years, and we never, not one of my bills ever even made it to committee to be discussed. And they weren't red bills or blue bills or anything like that, but they did not get the light of day. And finally, when we got into the majority, frankly, that's what happened. That's why those 2 bills were heard, and both bills were passed out in a bipartisan way. The background check bill actually was Peter King's bill, the Republican from New York that Mike Thompson, who owns more guns than probably half the room, Democrat, joined with him, and we finally were able to get that bill passed. But I mean, because of the politics, we never were able, again, to even have a hearing. I think it was the first time in 8 years in judiciary that they had a hearing around gun violence. So when people say, do elections have consequences? Does your vote count? Yes, your vote counts very much, and elections do have consequences. Again, because we're in the majority, that's why some of these bills are being called. Even, it was discussed earlier, my maternal mortality bill. I filed it last Congress, in the 115th Congress. They made sure the Republican who had a bill not even close to the bill we have, not as thorough, but a good first step, they made sure that her bill was called and her bill passed, and my bill got passed along to the 116th Congress. So hopefully, with us being in charge, it will at least get out of the House, and then Senator Durbin can get it passed in the Senate. Again, it's not a red or blue bill or anything like that, but gun violence has definitely suffered from the politics of Congress and the NRA, as we well know, and that's what our bills have to go through, frankly, if we are not in charge.
And it's not as if you're against guns.
No,
Congresswoman.
I even though Bobby told me to stop saying that. I'm not against guns. I don't want one, and I've never touched one, frankly. But if you have yours and you have it legally and you're not trying to hurt yourself or anybody else, then you have a right to have your gun. But I represent some of the Chicagoland area, and my young people have a right to walk to the store, walk to school, play in the park. take a bus ride, get off the bus and go to Starbucks and get a cup of tea without being murdered, you know. And I often talk about, we discuss the mass shootings, they get a lot of the attention, but we forget about the everyday shootings that occur. I was sitting next to one, I think David Cicilline, one of my colleagues, and I was showing him. I said this was a Tuesday, and in Chicago, 1 person died, 6 people shot. On a Wednesday, 7 people shot, 1 person died. It's not just the weekend. It's not every other weekend. This is occurring every single day. So this is a crisis. And when we talk about post-traumatic, one of my ministers said that they have present traumatic. It's not post, because what they have to deal with every single day.
I wouldn't be a good millennial, please.
On that too, because we've heard a lot about the suicides at Newtown and Parkland because of the trauma inflicted on those school shootings. And obviously, the people subjected to that in Parkland and Newtown should get significant support. But we should not forget, as Robin just mentioned, that this is an everyday occurrence in some cities, and those children going to school need the same kind of support that the people in Parkland and Newtown obviously need. And we should not forget the problems with trauma in all of our students.
And Congressman Scott, if you can keep going on that thread and talk to us about your mental health initiatives and such like that, please.
Well, in terms of mental health initiatives, as I indicated, the Affordable Care Act, because mental health is an essential benefit, people have coverage. The president was bragging a little while ago about $200 million or a few $1 billion he put into mental health. And I pointed out to him that he was ignoring the fact that he was putting tens of billions, maybe hundreds of billions into mental health by the passage of the Affordable Care Act, and the fact that that was an essential benefit. And so we need to make sure that we don't do anything to sabotage the Affordable Care Act. We need to be building on it, not taking it back. And as Sheila indicated, Democrats read the bill. Nancy Pelosi rounded us up and stuck us in briefings day after day, section by section. We had experts. If you had a question, they'd stop at each section. You got a question, there were experts in the front of the room that could answer the questions. Day after day after day, weeks on end, we went through that bill. We read that bill more than any bill. I've been there over 26 years. We read that bill more than anything that we've read. Now, I'll tell you who didn't read the bill. The Republicans. They didn't have anything to read. They were going to vote no. We passed a Republican bill, Republican Health Care, Heritage Foundation, Romney Care. That's what the Affordable Care Act was based on. We passed that, couldn't get a Republican vote on final passage, House or Senate. They didn't have anything to read, and because they didn't read it, they're sitting up here thinking you can protect pre-existing conditions without significant subsidies or mandate, right, and not have the thing fall all apart. When you look at their plan, when they finally got in control, when they put their little ideas together, tens of millions fewer people with insurance, costs go up, benefits go down, people with pre-existing conditions start losing, and because they didn't read the material in the background.
Mm-hmm. But you know, something I don't understand when they take the mandate away. If you don't have insurance, and this could happen to anybody, then you get in a car accident and you have to go to the emergency room. So who pays for that?
Well,
we do.
Before the Affordable Care Act passed, people with insurance had about $1,000 in a family policy embedded to cover what's called cost shifting. The people that go to the emergency room don't pay. When you go to the emergency room, you got to pay a little extra to cover that. That's about $1,000 in a family policy. Mm-hmm. And now that everybody is supposed to have insurance, including Medicaid, that cost shifting has gone down significantly.
But I mean, when they say you don't have to have insurance, people aren't invincible, and then when you get hurt.
And that's what it was before the Affordable Care Act that they like to forget about.
Mm-hmm.
Yeah. I wanted to bring you in, Congresswoman Jackson Lee, to talk to us, to continue this conversation, but then also help us to understand, especially because the larger theme of this conference this year has to do with diversifying the healthcare workforce. Dr. Gary Puckrin is around here somewhere. There he is. Okay. Dr. Puckrin likes to talk about we're moving into the new majority, right? So by 2026, if you all haven't read this just yet, by 2026, the country will no longer be majority white or European. It will be people of color who, in terms of demographics, represent majority of the nation. And so with this new majority, with considerations of diversifying the healthcare space, Congresswoman, how should we think about the ideas of immigration? And then Congressman Scott, if you want to talk to us about graduate medical education and talking about opportunities for persons who aren't born here but bring their medical background, we can do that.
Jump in at the education piece after them.
Well, first of all, Mia, let me thank you. You're not Dr. Matthews.
I'm not. By the way, she's ill, so we can send good energies out to Dr. Matthews.
We'll send good energies up to her, but I certainly want to give your name and a wonderful health policy advisor in Congresswoman Kelly's office.
Thank
so
you.
We're delighted that you are here with us. That's a very good, very important point. And if I might lead into that point by suggesting just a little bit more about the mandate. The mandate was actually a pretty unique, or at least pretty savvy way of adopting a methodical basis of funding. And it had to do with cultural norms being changed. And that is, when I'm young, I'm invulnerable, don't need anything. And I think if we had allowed the Affordable Care Act to, as they say in houses of worship, make its way and follow cultural norms, or at least get ingrained in young people that there's nothing wrong with having an umbrella on a rainy day. And the idea, of course, was this whole question that Congressman Scott said, that you would have a pillar, you would have a foundation for those who are more sickly, but yet you would have the support of a younger person in a catastrophic accident, which is typically what their illnesses are. And left to its own will, people would have gotten used to the idea of the mandate. The name could have been changed, investment in yourself, or making yourself feel good. I don't care what they called it. They would have gotten used to it, just as we couldn't get enough hugs after we were devastated in 2010, meaning Democrats lost brutally. After that, people were hugging us because they got to understand what it meant when they had health insurance for their children, that they didn't have caps when they were in the hospital. I always used to use the example, how many people got to knock on the door in a wheelchair and said, thank you, your time is up. And all of that had changed, and people were excited. And it really is destructive that the Republicans, with no answer, started dismantling the Affordable Care Act, including not allowing states to have the expanded Medicaid, which those who took it, again, West Virginia in particular, was a whole new attitude, a reformation of their health care. That goes to the question of immigrants that you've mentioned. Immigrants, individuals who are statused and some unstatused. Most of the unstatused people are in our public health system. And I remember when we were doing the Affordable Care enrollment, you can be assured that these families who had been here for years and paying taxes and working, not realizing what their limitations were, they were in line to enroll. And of course, they could not be enrolled. But it just simply says that healthcare and the professionals that are in this room and diverse professionals are crucial to the livelihood, the economic success, and healthcare of this nation. Do we want a sick nation to be competing against the world's countries? That's what has been our strength. Do we want a military force of sick children going into the military, or strong people who've had a good, vibrant, healthy upbringing? So I would just say that we need to be prepared for the medical needs of individuals who are diverse, some who have been in this country for a long time, some who are the children of those who are immigrants, they are now citizens, and be prepared to have the kind of knowledge that the Affordable Care Act was prepared to provide you with, and to make a difference in the lives of immigrants. We will not be able to run away from treating immigrants. And I guess the closing point is, coming from Texas, the 2 children that died at the points of entry stations died because of the inability to access medical care at that site. And most people don't know, no ambulance came for them. The Border Patrol agents had to rush them in their car to a medical facility because there is no, and only after this Congress made such an outrage of noise that when I went down last couple of months, they had put Coast Guard medical care there, and that was like a table and a Coast Guard doctor in a chair and a room where you could go in and see the patient. But this is going to have to be something that we confront, and this issue of diversity is going to be extremely important.
Well
There
said.
was one, we had 12 benchmarks. I'd say 8 or 9 where we met completely within the ACA. A couple were, maybe 2 were partially, like the territories. The one, and we fought for this all the way to the end, that immigrants, legal or whether they were here legally or not, would be able to utilize the services provided by the ACA up to the very end. But we could not get it done.
Yeah, these are
Work yet
crucial
to be
times.
completed.
We really did.
Yeah.
Because, well, we saw what the downside of them not having health care. Because it's mostly our local governments, and I think that's true, Robin, Bobby, my local government and its health care system takes any sick person in. If you're in that jurisdiction, we take any sick person in, but that's the public local health care system. And interestingly enough, the local guys made the decision, and I want to say to you, my local guys said, is there any way I can get the expanded Medicaid? Can I bypass the state? They were begging. We were trying for a period of time to work with the former administration, but again, it was through the state, but they were begging for the expanded Medicaid in these counties in the state of Texas.
And not just, I know you wanted Bobby to talk
Please.
further about the diversity part, but the other thing that I worry about is geographically, like the rural areas. My district is urban, suburban, and rural, and even though the rural part is not that far from the city of Chicago, but what they don't have is shocking, you know, the lack of access. And one of my hospitals is really doing yeoman's work to try to change that, but the lack of access, how far they have to drive, and those kind of things is a big issue too. And around counseling and that kind of thing, they've started doing telehealth, and even with other things also, but just my constituents that live in rural areas and my colleagues, especially those that represent the South, they have to deal with that so much,
Over
the
and
lack
over
of
again.
access to care.
This is why I know we're synced, because that was my next question for you. But I want to come back to that, especially the telehealth part. Congressman Scott, can you talk to us about opportunities?
Well, we know what the problem is, that we need culturally competent providers. We know that, as Sheila indicated, they mentioned on 60 Minutes, that there are no more black men in medical school today than there were 50 years ago, and we're already underrepresented. But you're not going to, we know what the problem is. The solution cannot be accomplished overnight. You don't suddenly qualify for medical school your senior year in college. That starts with pre-K to make sure people don't start off with achievement gaps, all K through 12 to make sure people aren't dropping out. College, make sure you have access to college, because if you're not in college, you know, if you've kind of winnowed out getting into college, you're not going to have the number of people necessary to continue on to medical school. And then New York University may be giving tuition-free medical school, but I can assure you that the other ones, you're talking probably an average of a couple of $100,000 that people have to be willing to incur as debt. And when people who are not of means look at the idea of $200,000 in debt, that is it serves as a great deterrent in going in that direction. So we have to fix the entire system, make sure people are encouraged to go into the STEM fields. But you're not going to suddenly say, well, let's do something for medical school if you don't have the number of people who have in the sciences, don't have that background in college, and you don't do there until you've done it in high school. So we need to improve the entire education system to do something about the lack of minorities in medicine. That's what we attempted to do with the Every Student Succeeds Act a couple of years ago. That's what we're trying to do as we reauthorize the Higher Education Act, make it possible for people to actually go to college. When President Johnson signed the Higher Education Act in 1965, he says that admit that any student in any state can apply to any college and university and not be turned away because the family is poor. And in fact, you could go to college, work your way through college, and come out with no debt. If you're willing to work a summer job and about 15 hours a week at a minimum wage job, you could work your way through college. Now you can work 40 hours a week and can't afford to get out of college without crushing debt. And we have to go back. There are a number of reasons why that's true. States used to pay 2/3 of the cost of college. Now it's 1/3 or less. Pell Grant used to cover 75% of your tuition. That's about 25%. Cost of college has gone up a lot more than inflation. You add all these up, people are not able to go to college, and in fact, people are being turned away because they're poor. Because if you can't get some kind of scholarship, or if you're unable to borrow a whole lot of money, and we had a debacle a couple of years ago when the Department of Education cut back on Parent Plus loans. Hundreds of students were leaving. Each and every historically black college and university lost hundreds of students through that debacle. People that already registered and then couldn't, without the Parent Plus loan, couldn't afford to go. So we got to cure all those problems. So we have more people graduating from college in the STEM fields who are eligible for medical school, and have to do something about the medical school. We've got the health corps. Where people can work off their
National Health Service Corps.
Yeah, to make sure so people can go into a low-income area and get some of these loans converted into grants. We need a lot more of that, but it's not going to be one little thing. We've got to improve the entire education pipeline to make sure that more people are headed in that direction.
That's right. And had you wanted to add to that, Congresswoman? No. Okay. We're going to, do you mind if we go to questions really quickly?
No.
Okay.
I don't mind.
Okay. And then we'll come right back to what you've got to say.
Ahead.
Please don't forget, because I also want to come back to the Chuck Grassley conversation too, and the telehealth bit. Let's take questions from the audience. As you all come up to the microphone, really quickly about NYU and what they're doing with their medical school. So they're opening up the doors. They're trying to reduce debt and increase opportunities, right?
Situation, because one guy gave $100 million and raised a total of $350 million to endow the scholarships. That's not something that's going to happen at a lot of colleges.
But the thing is, the reason why they did that specifically is because they're trying to increase the numbers of family physicians, of family doctors. That's really what the impetus is, and to reduce the debt, especially because family physicians aren't getting paid in the same way that providers from across the sectors are getting paid. But that shortage bit is terribly important. I'm so very glad that you talked about it from a perspective of looking at kindergartners and on up. Let's take this first question, and then we can go from there.
Sure. Good evening. Thank you guys so much for all being here, and thank you guys all for being champions on these issues. It's really great to see people in Congress fighting for health equity. My name is Brett Rudy. I'm with the Association of American Medical Colleges, and something that all the panelists kind of touched on was the idea of trying to create a more diverse pipeline in the health professions programs. And the HRSA Title VII and Title VIII programs that Dr. Christensen spoke about so great this morning with the Health Centers Opportunity Programs. Every year since the president has come into power, he's tried to eliminate all these programs, such as the HCOPs and the Centers of Excellence and the scholarships for disadvantaged students and nursing workforce diversity, with such a low participation in minorities in the health professions now and the need to create a more culturally competent health workforce. Can you guys please elaborate on any efforts you hear regarding these really important programs in Congress as they're up for reauthorization and, according to the president, wants to eliminate and zero them out?
I couldn't even hear.
Congresswoman, please.
Well, let me just say with the present House, I am almost certain that we are going to keep and or plus up the programs. Both Ms. Scott and myself sit on the Budget Committee and in the House, and we passed a plus up on what we call non-defense discretionary spending. But our appropriators are committed to these programs now under the chairmanship of individuals in the majority. These are important programs, and again, remember what I've said, follow the facts. That's the business that you're in as well. Statistics, the numbers of graduates, and if we follow the facts, there is no doubt that these programs dealing with the ability to heighten the numbers of diverse persons in medical professions is needed desperately. So I don't know, my other colleagues can say it, but I don't think that this program, well, let me say, the president's budget as submitted was dead on arrival. No one is going to adhere, no one is, our friends on the other side of the aisle, they didn't propose that budget. So we believe that there are certain elements that will be addressed through the budgeting process, but more importantly, through the appropriating process.
And I thought through approach what Congresswoman Barberly was saying, that we were able to get more money in for certain things, like for schools and other things like that. You can speak to that better than me, but even though he is in the White House, but we were able to get some things done.
Well, one day we're going to become fiscally responsible and recognize that you can't have, between the Bush tax cuts were about $4 trillion and the Trump tax cuts $1.5 trillion. They don't pay for themselves. You've got to pay for it, and we've been paying for it with deficit spending. At one point, the interest on the debt, we're at a historically low interest rate now. In a couple of years, we'll be paying as much on interest in the national debt as we're paying on national defense. And this is particularly egregious because when President Clinton left office, we were on track to paying off the entire national debt held by the public by 2008. But because of massive tax cuts, 2 wars not paid for, and a prescriptive drug benefit not paid for, we're way back in the ditch. So at one point, sometimes in the future, we'll get back to where we're going to be fiscally responsible, but it's apparently with this president, it's not going to happen this year or next year.
I appreciate that you're still optimistic, though. Let's take the next question.
You know, we did it. Under Clinton, we did it. Not a Republican voted for the Clinton budget. It was the right thing to do. They demagogued it. They took over the House, demagoguing the votes. When you vote for a responsible budget, they are, for many of your colleagues, career-ending votes because they're going to get you at the next election. And you just need to, same thing with the Affordable Care Act. People voted for it knowing they couldn't win the next election if they voted for it. And if we're going to have fiscal responsibility, it's going to take that kind of political courage.
That is so significant because essentially what you're saying is policy design is not without politics, right? Yeah. So again, I can't tell you who to vote for, but make sure you vote. Let's take this next question, please.
Thank you for an excellent conversation. My name is Khadija Bretha. I'm a heart failure transplant cardiologist at the University of Arizona. I actually spend most of my time as a physician scientist. I'm also a 40 under 40 winner. And so a lot of my research does involve health policy. And my question to you is, how do myself, as well as many others here, use our research to help change and inform health policy?
Well, we love when, especially as chair of the Health Braintrust, when people contact our office, because when you have new information, that can help us push policy, push new legislation. So that's, I mean, one way. And speaking with other members of Congress also, we encourage people to contact us and see how we can work together. We've traveled the country doing different things with different groups and different legislators that have wanted us to come in. So yeah, share your knowledge. Don't keep it to yourself.
And it's also important that you work with national organizations. Listening to one person is difficult for a policymaker, because I don't know if your research has been peer reviewed or what people think of it. Might be a bright idea, might be a good idea, but not a priority. When a national organization, say National Medical Association, comes up with a list of priorities that are backed by research, that's extremely helpful, because it's gone through some kind of research, it's been peer reviewed, and there is an analysis of what's important and what's not important. When you get these things one at a time from one person, it's hard for a policymaker to kind of evaluate where on the priority list it ought to fall.
And we work with national groups a lot.
So becoming a member of some of the national groups and then infusing the research through them will be helpful.
And vote for people who are going to listen to the science. Because as I told the group on Saturday, even research that Congress pays for is not necessarily considered. Politics often will trump the science. So vote for people who are going to listen to the science and act on the research that you're doing.
We'll have 2 more questions. Yes?
Hi, Maria Pugliano. I'm an ophthalmologist in Chula Vista, California with the California Latino Medical Association. And there's some things that I just do not understand about the United States. One, we're the richest country on earth. Second, we are the only developed country that does not have universal health care. We're the only developed country where every single resident has the right to a roof over their heads. In this country, we do not have a healthcare system. We have a healthcare industry. In the last 20 years, in Spain, European country on the verge of bankruptcy, the incidence of blindness has gone down by 75%. Whereas in the United States, where we benefit from the same advances, basically it's unchanged. And that's because of lack of access. For the physician in private practice, the Affordable Care Act has really not helped too much. The really great thing that has happened is the expansion of Medicaid, which has made it possible. Oh, and by the way, the leading cause of blindness in the United States is not diabetes, it's glaucoma, which can be detected early and treated, controlled. So, you know, we have to do something. There are too many vested interests here. Talking about medical school, in Western Europe, it costs 200 euros to go to medical school. In the United States, even California, it's $36K a year. So we have to look at the big picture. We are a first world country. We are a great country. We just have to show some respect for the people who live here. And by the way, it's not fun being a doctor anymore because you've got so many pressures. You have to produce. The humanity is disappearing. Thank you.
Thank you. You gave us a bunch to address. Let me just unpack and tell me if I captured it all for the members. So we haven't talked about universal coverage, and we haven't talked about anything on that continuum. So if we can address that, and then also talk about the load, you know, the heavy load on physicians, especially now that care of practice practice management has changed. And then I don't know so much that we'll talk about glaucoma, but that was a really good point that you made. Yeah.
I think the doctor said that this morning, the ophthalmologist. Yeah.
Okay, can we talk a little bit about universal coverage and whether or not so much, do we have an appetite for it? Do we even have a setup for it? Are we ready for anything like that?
Are we ready for universal coverage? I mean, I think everyone wants it, but if we're going to be honest, that I think it's not easy to get there. You know, if it was easy to get there, we'd be there, and it may not be easy because of the different factions that you spoke about. But we are the richest country in the history of the world, and it is ridiculous that everyone doesn't have health care. I'm a member of Congress. I'm married to a doctor. And when my sister-in-law, my husband's sister, told me I don't have health care, this was like last year, because I can't afford, I think she said she couldn't afford the premium, to pay it every month, what she would have to pay. I was like, oh my, this is horrible, And then she was explaining to me, and I'm on Energy and Commerce, and we just had a hearing on junk insurance, that people got insurance and they thought the insurance, covered, and then when they really needed it, it didn't cover what they said they needed. But I do think we still need to work on universal health care, and I know people want to call it different things, and but we just have to figure out how we're going to get there.
The CBC has always begun that with the principle that healthcare is a right, and therefore having everyone have coverage is something that we should have. If healthcare is a right, everyone should have access to healthcare. How we get there has been the problem. The devil has been in the details. But I personally think we need to work on improving the Affordable Care Act. We lost track of the public option last time. We need to bring it back and try to get that in as a step to getting to universal coverage. I know some people don't agree with that. They think we should go straight to universal coverage. I think one of the provisions of the ACA that did not continue was finding a way to cover the early retirees before they got to 62. 55. So those things need to be brought back in so that we can work towards making sure that everyone has insurance coverage. One of the things that the ACA did too was expand on community health centers, which allow people who don't have insurance to get decent health care. They are really the stalwarts of our healthcare system. Without them, many more people would not be able to get health care. But health care is a right, and we got to figure out how we're going to get everybody covered. We just got to work towards that end.
Another thing that we need to talk about is that the United States is ranked 37th in quality of health care in the world, according to World Health Organization. And so we're paying a fortune for getting very little back as a citizen.
I think Congresswoman Jackson Lee is going to also speak.
Well, let me just thank you and indicate that we have an obligation to those of you who have made a commitment to the Hippocratic Oath to have you enjoy it and have you be able to take care of your patients. I think the Affordable Care Act was bifurcated into two prongs, and one of them was to make private insurance better. And there were many of us who wanted and worked very hard for the public option. And the compromise on the public option was the expanded Medicaid, which really has been, if it had been accepted and taken up by all 50 states, would have made a miraculous change in health care for Robin's sister-in-law and many others. I would say with a little issue that the Affordable Care Act did do some things, allowing young people to stay on until they're 26. It did make an impact on prescription drugs. The no capping on care was unbelievable. So there are some good things. And I think what happened was, as my colleagues have said, you have to work on a bill. So the idea of the premiums going up, that was a result of insurance company manipulations and not being in some states and being in others. So that's the first order of business. I think we did make a dent, but we can always do better. This is very complex. And for the purpose of discussion, I think Medicare for All should be on the table. All of the proposals should be on the table to see how we can access universal health care in the best way possible, and also maintain the resources that physicians need, having gone through medical school and having to have, if they're in private practice, overhead and taking care of their patients. And so I think there is a method of looking at everything. Quality is one of the elements in the ACA. We're not where we need to be. 37th is not a number, unless you're 37 years old, is not a number I want to hear about, because that is not a good number. And of course, everybody up here is 37 and under, but that is not a good number. And for those of us who've had friends or people, constituents, and we get involved in the medical care or family to help those constituents or friends or otherwise, we see what happens. Denials on coverage, after you have a stroke, denying you rehab dollars, which I just went through with a constituent. They wanted to send the person who's vigorous to a skilled nursing home. No disregard to them, but this person wanted to come back alive again. They wanted to go to rehab. And we had to fight for them to go to rehab. So I'm saying, hang in there with us. The Affordable Care Act was much better than you might perceive, but we do realize that things needed to be done. And for universal care, if we don't get in the mix of the fight of what we will have, including some of those that people like and dislike, we'll never get it done. So I hope you'll join us in that. Thank you.
Thank you.
We'll take a, yes, sir.
We're going to get there because of the basic arithmetic. If we have universal coverage, Medicare for all, or whatever you want to call it, as a society, we'll be paying less, more people will be covered, and the insurance policies you get will be better than what you got today. That's an arithmetic reality. The problem is you can't get there in one jump, because if people get rid of the policies they've got and go there, you'll be talking some number that's way over and above what anybody would want to be associated with in a legislative process. But if you start with, when we said the Affordable Care Act, we did the same thing. They said, look, we got everybody, a lot of people already covered. If you can lock in what you got and just cover the people that aren't covered, it's going to be a lot easier thing to do. So we had an employer mandate, because most employers, particularly large employers, were providing it already. Don't let that go. And so we had a much smaller pool to deal with. The public option, if we could have gotten that, and we're a lot closer than people think. It passed the House and got over to the Senate. Scott Brown had taken Kennedy's seat, and we were messed all up, and we were one vote away from the public option in the Senate, and it fell apart. So I mean, it wasn't like it's a pie in the sky idea. We were that close to passing a public option. And what happens if you put the public option out there? One Republican said that the public option is unfair because is wrong because it's unfair competition. Well, think about that for a second. That means you get lower price and better insurance. And so his idea was you can't have that. Well, the rest of us said, well, that looks like a good idea. And if you get the public option out there, more people will buy it. It'll get much bigger market share, and gradually you can get employers buying into the public option, and it will grow to where it will cover as many people as you want. If people want to hold on to their more expensive, less beneficial insurance, let them do it, but everybody else should have access to a public option where you can get better insurance at a lower cost and unfair competition. We had to pass a law in the Affordable Care Act to keep insurance companies from charging more than 20% for administrative costs. Well, the administrative costs in Medicare is about 2 or 3% or less. And so the public option is always going to be a better deal, but you just can't get there in one jump. Medicare for all, if we just go in that direction, we will get there eventually, because as a society we'll be paying less and getting more.
And with I'm sorry, were you
I
going to say?
didn't want to forget about him.
I know there's one more question. Yeah. Sir, if you can give it to us real quick, and then the members can give us our 30-second answer.
And one comment. I'm
Yes,
Jaime
sir.
Davidson.
Well, if you can just give us our question.
I'm an endocrinologist from UT Southwestern in Dallas, and I wonder why not, we need minority nurses, we need minority doctors, there's no question about. And one way to do it is because many people that qualify don't have the money if they are minorities, And why not the states have some money left assigned for those that qualify, because not everybody qualifies to be a nurse and a doctor, and give, a percentage of that money to those people that qualify to go to medical school. And my other comment is for you, why not all of us have the same coverage that you have in the Senate and in the Congress? Thank you.
Well, let me answer that last question first. Members of the House and Senate and their personal staffs have the same coverage under the Affordable Care Act that everybody else has. We had to go and search the internet and had access to exactly the same policy that everybody else had.
We had to go into the exchange. We went into the exchange.
But that
And we pay.
Yes.
That's what people think, we get free health care, but we don't. In fact, this is the most I've ever paid for health care.
Actually,
I
I
always
paid
wanted to
more.
say, thank
I
you,
paid
President
more
Obama.
when I was in the exchange. That I'm retired now, so now that I'm retired, I can go back into the federal, and I paid twice as much in the exchange as I
I pay more now than I've
in
ever
the
paid.
exchange.
Right.
Yeah, than I pay now in a private in Blue Cross Blue Shield.
But people think we get it free,
Yeah, I
which
know.
we don't.
I'm really glad you asked that question, sir, so that they could debunk the very pervasive myth. I do want members to just take 20 to 30 seconds to close, but just to surmise what we talked about, certainly diversity in the healthcare workforce, coming to grips with the fact that our nation's demographics are changing, and thus our healthcare needs are changing. We've got to be a lot more open to innovative solutions, including telehealth. We need to be mindful of the opportunity pipeline with respect to STEM, especially STEM education. And we need to be a lot more transparent with respect to what our healthcare system delivers and what it doesn't. So having the hard conversations is important. You see these members of Congress are open to have the hard conversations. Be in touch with other members. I can't speak for all of them, but be in touch with them, right? And ask them to have the conversations with you. I'll ask for closing remarks from the members.
I'll just thank all of you for taking the time to be here and to listen to the conversation, for challenging us on what we have to do next. As the chair of the CBC Braintrust, closing the gap of healthcare disparities will always be first and foremost, and diversifying the healthcare pipeline is extremely important. And as my colleague said, we can't start in college. We have to start from first and second grade, so our young people even know what the possibilities are. And we are working really, really hard toward that. But for me, these next few months, I will be working very hard to pass my maternal mortality bill, because you talked about us being 37 as ranking in healthcare, and to be a developed country and be 32 out of 35 is pretty poor as far as women dying. So thank you so much.
That's HR 1897, the Mama Act. So yes, Congressman.
Well, if you're talking about the Affordable Care Act, I think in 30 seconds, I just remind people what that old man was praying. He said, "Dear Lord, I'm not what I ought to be. I'm not what I'm gonna be, but thank you, Lord, I'm not what I was." That's the Affordable Care Act. We're gonna do better, but it's not as bad as it was.
I like that. I like that a lot.
I'm going to try to add in real quick what I wanted to say in the education piece. I am always concerned that with all of the wonderful advancements in healthcare, that we're going to be still not able to access them. They're going to be expensive and so forth. One of the ways some of us are trying to address it is by bringing more research and development into our HBCUs and our minority serving institutions, so that we can be a part of the research on precision medicine and the provisions of the Rapid Cures Act. What is it?
The Cures Act, the 21st
The
Century.
21st Century Cures Act, participating in the Cancer Moon Project, and all of those things. It not only brings us into the mainstream as things are advancing, but it also helps our HBCUs. by bringing those research and development dollars into our universities, and it has the potential to lift up the communities that surround those universities as well.
Very good points. Thank you. Congresswoman?
Yes. Let me have time not taken away from my 30 seconds to thank everyone, and to certainly thank our chairwoman for her leadership, and then thank my colleague, Congressman Scott, Congressman Christensen, and of course you, Mia. But I just want to give, I started with statistics, so let me see if I'm still got 25 seconds left.
Go ahead.
Men make up over 75% of suicide victims in the United States, with one man killing himself every 20 minutes. Men living in small towns or rural areas have particularly high rates of suicide, and the weapon of choice is usually a gun. American children die by guns 11 times as often as children in other industrialized countries. So I want to end on the fact that I too agree that the Affordable Care Act has made great strides, but I believe in certain aspects we have a national emergency as it relates to certain health factors. And I would include suicide and gun violence among children, but I would also add that the diverse medical professionals in this room need to take up the issue of the rising opposition to vaccinations, and more of a assessment on infectious diseases. Ebola, Zika obviously was in our community, was come about through transfer through mosquitoes, but measles have taken their toll on a number of communities, and we need to, my view is, let everyone discuss their view. Let everyone discuss their view on vaccinations, but let those who believe in vaccinations have a voice as well to encourage parents and families to think about what the impact is without vaccination. So if we don't tend to certain elements, it will become a national health crisis, of which I believe gun violence has already become a national health crisis. And so all of you in this room are vital components to the quality of health care in America, and also saving our children. Thank you all very much.
Thank you. Thank you very much. And all, please enjoy your evening. Just one more time, Congresswoman Sheila Jackson-Lee from the 18th District of Texas, Congresswoman Dr. Donna Christensen, I'm off, okay. Congresswoman Donna Christensen from the U.S. Virgin Islands, Congresswoman Robin Kelly, 2nd District of Illinois, and Congressman Bobby Scott from the 3rd District of Virginia.